We're going to be talking about the etiologies of selected shoulder pathologies. In this case, it's for degenerative labral tear, degenerative tendinosis, and acromioclavicular pain and other causes of AC dysfunction, AC symptoms. But first, I need to answer some of the questions I posed you about causes of instability on the last video. In order to cause a labral tear, degenerative labral tear, outside of severe trauma, but also including overuse syndrome, because obvious overuse, where you've done something unfamiliar but really excessive, is likely to give you a history of deltoid pain, shoulder pain, and acute shoulder issue. Healthy tissues, when it tears, isn't happy. So we're really looking at degenerative type, which may have overstressing as a trigger, but there's already degeneration present, generally speaking. So how do you weaken the labrum? Well, you weaken the dynamic stabilizers. The labrum is actually the mid-range stabilizer of the shoulder. End range, the capsule and ligaments take over, but for mid-range movements, before the capsule is fully tight, it's a labrum. This comes down to what we spoke about last time, and that's compression concavity stabilization. So the labrum increases the concavity of the shoulder joint considerably, and also it extends its surface area to make it more stable. But it does need a lot of dynamic stabilization, as we looked at last time. This is basically the rotator cuff and the biceps long-headed. So we need to weaken these, and we can do that in any number of ways. Neurological causes include an exoplasmic flow compromise, both structurally and weakening its force output, and then also neurophysiologically with segmental facilitation and reflex inhibition. We can damage the inert stabilizers as well. So we can damage the labrum, and this can be done gradually with microtrauma over time. And what you can then end up doing then is overworking the dynamic stabilizers, so they actually become tendinotic, and that damage to the inert stabilizers can also lead to reflex inhibition. So you get this feedback loop here. So the labrum can be damaged, and the capsule and ligaments can be damaged either by trauma again, earlier trauma, but not damaging necessarily the labrum, but earlier trauma, or possibly sustained stresses, because again the muscles are not holding properly. Now, if we're looking at these stabilizers, now we're looking at the big muscles. For example, if you're abducting the arm, the adductors are going to help stabilize the humeral head and prevent it from over descending. So anything that's going to weaken them and lose their tone. So this could be a radiculopathy, or again reflex inhibition, or segmental facilitation. So the whole key to this is weakening the stabilizers. Again, to go back to the labrum, degenerate tearing of the labrum can be caused by overloading, mechanical stresses, anything limiting elevation rather, which includes abduction. So anything that's going on above the head can certainly damage the labrum, particularly the supero-anterior area. Anything working behind you with extension, which is much less common cause, can damage the other parts of the labrum. So anything for us, anything overhead, including abduction activities, can potentially damage this. If you've got full range elevation of the shoulder, then the chances are the labrum is going to be fine, as long as you're not overdoing that, so it actually does become a stress tear, if you like. So this could be caused by the AC joint not be able to take part in elevation as much as it should do, where the clavicle should actually glide anterolaterally, because the scapula is gliding posterior-inferiorly. So if this is jammed backwards and it can't go forward, then the labrum may be beaten up. Flexion subluxation of T3 to 5, where you need extension and ipsilateral rotation of the vertebra to accommodate that elevation, or a superior subluxation of the first or second rib are very potent in blocking elevation. So any of those could give you mechanical stress on the labrum that may degenerate it. Neurophysiological, we talked about just now, weakness of the dynamic stabilizers. So this could be C5-6 segmental facilitation with the rotator cuff or biceps long head, or it could be reflex inhibition from the glenohumeral joint itself from another injury. Could be neurological. Not so much a radiculopathy, although that's possible. You can have a painless radiculopathy. Stenosis is a case in point, but generally speaking, it's something else added onto that. Otherwise, what you're looking at is fast and slow flow exoplasmic compromise, leading to structural weakness and also false output weakness, or segmental facilitation, as we said, for neurophysiological, but possibly a neuropathy. Any of the nerves that supply the rotator cuff may also end up causing weakness of those muscles and therefore loss of stability of the shoulder, leading to labral tearing. Okay, to get too much further into the etiology, I need to talk to you a little bit about secondary reflex inhibition. Now, you've come across this, maybe not in language, but you've come across a phenomenon in the lumbar spine. Now, if you look at the Australian work on reflex inhibition, then what they'll tell you is the stabilizing muscles become hypotonic and weak and are unable to basically compress the joint surfaces together, which is fine. No problem with that at all. However, when you look at the lumbar spine, if you eccentrically test the strength of rotation, flexion, rotation, extension, you'll find it's weak. Now, this can't be because of multifidus. That just doesn't produce enough power to weaken those two big movements. So this is the abdominals that are weak when you do this. The abdominals, maybe the back extensors when you're going backwards, but primarily the abdominals. Now, these are not stabilizing muscles. You could argue the transverse abdominis is, but certainly the rest aren't. So the other way of thinking about this is that this is the way I model it anyway. Whether it's true or not, I don't know. But if you think about two segments sitting on each other that way, and the small stabilizers are weak, then when you actually produce a lot of force, as you do with an eccentric contraction, the segment slips a bit. And that slip then reflexively inhibits the abdominals. Whether that's true or not, I don't know. But the model seems to work. Because if we wobble the segment, then the multifidus comes back. Now, I've done nothing to the abdominals. In fact, the abdominals are not even innervated by the lumbar spine. So this is basically what you're looking at here is basically the multifidi stabilizing the segment, and then from that, somehow or another, the abdominals recover. So the model seems to work okay. Now, we see the same thing as we see in the lumbar spine. It's weakness of big muscles from segmental problems. But in the abdomen, in the upper thoracic spine, what we see then is weakness of the shoulder muscles. So, for example, if I get a dysfunction at T3-4, T2-3, T3-4, and I contract the muscles of the shoulder girdle below, so I test lateral rotation, abduction, for example. If I test them with the arms by the side, these are either strong or weak. If I test with the arm into its upper quadrant over here and push it down, for example, then that will be weak. So I'm testing the same muscles essentially, but just test them in a different range. And its breaking weakness is the same as it is elsewhere. If I then wobble T3-4, that upper quadrant weakness recovers, but the weakness by the side doesn't. That will recover when you wobble the shoulder. So to my mind, this tends to suggest strongly that you have two types of inhibition here as well. Primary from the rotator cuff, and secondary from the spine itself. It seems to work out okay. So I'm going to use that model when I'm talking about etiologies, because that dysfunction in the thoracic spine can weaken the muscles of the shoulder, and these are going to include the rotator cuff. If they're weak, then basically you've lost stability of the shoulder in those other positions. Low down, it might be fine, but up here, they're weak. And generally speaking, you'll often find both of them there. Both need to be treated, but you test it, find it, deal with it, whatever it is, whether it's local or whether it's secondary from the thorax, you deal with it. There is a couple of examples of how this process can occur. This is by no means exhaustive, but it's a couple of examples as to how this can occur. On the left, we see a patient who comes in with pain at the AC joint, and you determine that this is a biomechanical dysfunction of the AC joint, and you're looking for the etiology. And we're going to link T3-4 flexion subluxation with this AC joint problem. This is what we found as a possible etiology within the thorax, or right T3-4 flexion subluxation. Two ways of going with this. One of them is mechanical. If you do the upper arm, you go upwards there, that mechanical hypomobility can cause a labral tear, which can then cause a glenohumeral hypomobility, which can then cause an AC joint to overcompensate and break down. In which case, the AC joint is probably going to break down into the elevated position. That is because it's being forced further and further into elevation. The clavicle will sublux anteriorly in an anterolateral subluxation. If it's sublux in a posteromedial subluxation, it means that the AC joint cannot take part in the elevation process, and so it may be a contributor or even a cause of the problem. But in this case, we're taking this as a T3-4 flexion subluxation as a cause. If we come down that chart, you'll see it's neurophysiological. We see secondary reflex inhibition of one or more of the rotator cuff. This leads to a loss of dynamic stability of the shoulder, which in turn leads to a labral tear, which then causes, as a mechanical effect by blocking glenohumeral mobility to full range in elevation, and again the AC joints takes the beating. On the other diagram, we're looking at a degenerative labral tear now. We start the same way, T3-4 flexion subluxation in this case. And again, we can have a direct mechanical effect, and that's what that first line is showing. The flexion subluxation basically blocks elevation because that needs to be able to extend, and it can't, so it blocks that movement. And if we go up the chart, then it can also block it by causing an AC joint problem, which can then damage the glenohumeral joint itself. And between the two, the mechanical causes from the direct force of not being able to elevate because of the subluxation, but also the mechanical forces from the AC joint being disrupted, will then accelerate what's happening at the labral tear. Neurologically, we can be looking at an exoplasmic flow problem, and this can either be done by malnutrition of the labrum or by weakening the rotator cuff muscles, the stabilizers of the glenohumeral joint, and leading to degenerative labral tear in there. Going down the other way, neurophysiological losses, we have possibility of a secondary rotator cuff inhibition, and that leading to a degenerative labral tear because of the lack of stability. It's worth noting that if we're looking at T3-4 being the cause of the problem, the main etiology, or at least the primary etiology, then for neurophysiological issues such as segmental facilitation or reflex inhibition, the subluxation doesn't have to be in a position where it can mechanically block the joint. There's neurophysiological effects from it can occur whether it's extended or flexed or transversely subluxed. So we're just looking for that. You figure this one out by wobbling in the spine though. Okay, so the complaint now is shoulder pain, and we diagnose it as a supraspinatus tendinosis. Again, I'm using supraspinatus, but it could essentially be any of the rotator, any of the stabilizers of the glenohumeral joint. So we start again with a T3-4 flexion subluxation, just because it's what I picked, and we can go mechanically. So again, we get labral tearing, which will lead to a neurophysiological reflex inhibition, which will lead to muscle weakness of the stabilizers, and then that weakness will turn into a tendinosis, a degenerative tendinosis. We can go the other way as well. We can go up via the yellow arrow and go up. Mechanical problems, overcompensation at C5-6, and then if that's nociceptive, then neurophysiological segmental facilitation, weakness of the supraspinatus, and then degenerative tendinosis again. We can go down. We can look at neurophysiology from T3/4 flexion subluxation, secondary reflex inhibition. Again, now weakness of the rotator cuff, leading to a labral tear, leading to a primary instability of the rotator cuff muscles, and then a degenerative supraspinatus. Or again, that labral tear can actually lead to a mechanical overuse of the supraspinatus as it's trying to stabilize what now is an unstable joint, and it's overworking and actually get an overuse syndrome. If we go down again mechanically, it leads us to the AC joint, and if the AC joint is stuck in elevation, so we have an anterolateral clavicular subluxation, then again we'll have a mechanical effect on the supraspinatus as it tries to control things, and again that's going to lead to an overuse of supraspinatus. So again, this is not exhaustive. There are lots of other ways you can do this, and which one you start with depends on what you find. So if we're looking at supraspinatus tendinosis, I'm going to be looking for etiologies that make sense. So I could be looking in the neck, so I find a C5/6 problem, I see evidence of segmental facilitation. My next question is, why is C5/6 in trouble? Well, that could be mechanical stresses from the thorax. I'll look there, I find it. There you go. That's it. So it's not that I'm picking these things. Well, I am picking them out of the air, but you pick the one that you find is what you're dealing with. In this case, I'm stating that I'm finding the 3/4 flexion subluxation, and this is what's resulting in the tendinosis. So we can expand on this. So again, we have a diagnosis of a right supraspinatus tendinosis. And again, we start off with T3/4 extension subluxation. Now, this cannot cause a mechanical problem because extension is where you want to go. So this is extended, and it obviously can cause neurophysiological problems, but we're not going to do that just yet. The other way of looking at this is that this can cause overcompensation at C5/6. Now, if this is stuck in extension, overcompensation is going to want to move it into flexion. Now, if I've already got a flexion subluxation at C2/3, and I can't get any more compensation above C2/3 because that's blocking the movement now, then what I can deal with now is overcompensation at C5/6. Something's got to give. The C5/6 is in a vulnerable position at the beginning of that curve, or in that curve. So this one tends to take the brunt of it. That will lead to segmental facilitation, which will lead to weakness of supraspinatus, which can lead to tendinosis. Without that other problem at C2/3, this may not be an issue, but the fact that I've got that problem there means that it's got to be dealt with. So it's almost certainly going to mean you treating both T3/4 and the flexion subluxation at 2/3. And also don't forget, you have to deal with the tendinosis. This isn't going to magically disappear because you're taking the stress off it. The pain may go away, but the tendinosis is still there. So if you don't treat it, the risk of it coming back is that much higher. But that's your decision. You can either get rid of their pain and set them out and deal with it next time they come in, or you can deal with it at the time. I've got to admit, my preference would be to leave it until they came back with it. Okay, same problem, looking at a different way. We've got a T3/4 extension subluxation. As I say, there's no mechanical direct stress on the shoulder, but it can produce secondary reflex inhibition of abduction and lateral rotation quadrant. Seems to be the one that's most commonly affected, and that will lead to loss of dynamic stability and possibly labral tearing. So if the labrum is torn and you have an instability of the shoulder, the rotator cuff may become overused, and that will lead to a tendinosis. Or it can lead to, because of the damage to the labrum, secondary reflex inhibition of abduction, lateral rotation, and then again, direct weakness from that of the supraspinatus. So as I say, there's a lot of ways you can do this, but what you need to be doing is thinking about the process here. How does this happen? Not the exact steps, because the exact steps won't be present in everybody in that sequence, or even in that they may not be there. There may be other steps that's going on in this process, but the process is one where you're looking at the patient's complaint, the biomechanical dysfunctions that would make sense to cause that problem, and how they all link up. And this is that entire diagram, from the pain of supraspinatus tendinosis to the extension subluxation in the thorax, and we've gone both routes. But as I say, it's about processes, and this is one of the nice things about algorithm. It allows you to model these biomechanical neurophysiological processes that lead to pathology that makes the patient complain about it, but is being caused by a hidden etiology. As I've said before, hypothesizing that this is simple overuse isn't a hypothesis, because you cannot prove that. One person's overuse is another person's under-exercising. You can't prove overuse. You can prove unfamiliar overuse, but even there you can't say this is the cause of it, although there's a massive correlation between the two. So what you have to do is make a hypothesis that is testable. If you can't test a hypothesis, it isn't a hypothesis, it's a speculation. And with that type of speculation, as far as overuse is concerned, there is nothing you can do except say, stop overusing it. And they may not be overusing it, and that's the point. You may be preventing them from doing an activity that they're perfectly capable of if the rest of their body is dealing with the forces adequately. So your hypothesis should be testable, they should be rational, they shouldn't be too much out there. So it's all very well theoretically going further and further. You could argue that this is being caused by a cuboid subluxation of the foot. You could logically make that whole chain up into a supraspinatus tendinosis, and we used to do that, a lot of people still do. It's a bit far out, if you like, and it might be worthwhile moving down when you're having trouble coming up with anything, but sometimes eventually it gets a bit unreasonable. So your hypothesis and your findings should be both rational and reasonable, not just rational. So as I say, this is well worth you doing. I would certainly go to Lucid Chart, get their free program. They give you 3 charts to play with and start working your way through these processes. If you do that, you're teaching yourself, and teaching is the best way you can do this stuff. And you'll find out where it doesn't work and what it does, how it doesn't work and when it works. And I can't recommend this strongly enough. And it's the one thing you can do in these more complex modules that will actually help you master, as much as anybody can, master etiology searches. There you go. We'll be getting a lot more of this, and I'll be giving you some thought experiments to carry out with this type of problem, much the same way as we did in the previous module. Hope it helps. Take care, everybody. I'll talk to you soon. Bye-bye.